Hello, good afternoon, everybody. I'm Dr. Luis Mon from the Hospital Clinic in Barcelona, and my task here today is to chair this session that will be devoted to three main topics. The first is learning about the impact of implantable electronic devices infection. Also to learn about which patients are suitable for leadless parameters. And finally, what is the potential value of leadless devices with AB synchronous spacing? And to attain these objectives, we have the privilege to count on the well-known specialists in the subject. The first presentation will be delivered by Dr. Mauro Biffi from Bologna in Italy. And he will discuss about the results on the wrap-up study. How can we decrease the risk of infection after implantable devices? And I think it's really an extremely important issue nowadays because, as you know, infections are the worst complication that we suffer with implantable devices. After that, we will have Marta Pachon. Dr. Pachon is from Toledo in Spain. She will share with us the experience in leadless spacing. She has large experience in the field, and I'm sure she can give us a lot of useful information, tips and tricks, and what are the indications. And finally, we'll have Dr. Zaidi from Manchester in UK that will talk. He will talk about the new device, the AB synchronous spacing that can be delivered by the new leadless devices. This is certainly a very important topic because it will expand the indications for the leadless spacing, and it seems to work quite well. So let's see what Dr. Saidi has to share with us. So I think this will be a very productive session. You will have the opportunity to send questions through the chat and after each presentation. So I'll hope you will enjoy the session, and we'll keep on discussing. Thank you.
Good morning. Welcome to this focus on CID infection and the lesson taught by the ROBI trial. My name is Mauro Biffi from Bologna University, and these are my disclosures. CID infection is a life-threatening event despite complete hardware removal and antibiotic treatment. The prognosis is worst in those patients with endovascular infection only, whereas kind of more favorable in those patients with pocket infection only, and is intermediate for those patients who have in-pocket infection as also endovascular infection. 3/4 of CID infection involve the surgical site, which is the pocket, and this is where what we should focus on. Beyond being life-threatening, CID infection also poses a huge economic burden on health system, with an average length of hospital stay between 25 and 30 days, and the average cost to treat the patients as 30,000 euro per patient. So it is intuitive that being no curative approach to CID infection, CID infection prevention is the key strategy in our patients. The PADI trial involved a prophylactic strategy of prolonged antibiotic prophylaxis over the time needed to have a nearly complete wound healing, means 7 to 10 days, with both short-acting and long-acting IV prophylaxis, plus pocket wash, plus oral cephalosporin up to the 7th day. This study involved 20,000 patients and had as primary outcome hospitalization due to device infection. Despite showing a 23% reduction of the primary endpoint, this was not statistically significant, and at the number needed to treat as high as 500, barely feasible to be translated into clinical practice. Meanwhile, we learned from literature that many of the deficiencies shown by the IV antibiotic prophylaxis are covered by minocycline and rifampin, especially when these are delivered locally to prevent surgical site infection. how can we deliver antibiotic prophylaxis for a prolonged time until complete wound healing occurs, so the internal of the pocket is completely sealed against the external environment? There is one way, which is a sustained release by a polymer that is wrapped around the implanted system, the generator and the leads in the pocket. This enables sustained drug delivery up to 2 weeks and is active against MET-resistant cocci, non-staph pathogens, and has high bactericidal concentration without systemic effects. This is the specific kinetics of the 2 antibiotics released by the polymer that in the end absorbs within a few weeks, leaving no nest for further bacterial seeding. So coming to the ROPID trial outcome, we learned that the control arm had a very low event rate. And we are talking about CID replacement or upgrade. The treatment arm had a 40% significant reduction of overall infection with a number needed to treat of 200. Splitting the population into low power, pacemaker replacement or upgrade, and ICD-CRTD replacement upgrade, it is clearly understood that the major benefit occurred in the more complex devices, ICD-CRT, with a 50% reduction of overall infection. Diving deeper into the data, not only pacemaker had little benefit, but also first CRTD implants had little benefit from a prolonged prophylactic strategy via the envelope. The greater advantage being observed in ICD-CRTD replacement or upgrade of revisions. Here, the reduction was 70% with the number needed to treat as 100, really attractive for broader implementation in the general CID population. So we understood that both the complexity of the procedure and the complexity of the device are a hint to an improved outcome related to the use of Tyrex. Gathering together the ROPID and the PADID study, we had 27,000 patients who had a very low infection rate in control arms, raising the question whether this is the real world of clinical practice or the reality of randomized trials only. Indeed, real-life clinical registries show an infection rate ranging between 2.5 and 3.5%. The retrospective nature of consecutive patients clearly highlights that medical attention to the infection risk and enrollment into a prospective registry halves the infection rate. This was observed in very complex devices and procedures, just like those of the RAPID trial, with the same infection rate as in the control arm of the ROPID. And once you observe what happens after an audit takes place in a center, the infection risk is already being very low, nearly halves by strict adherence to a preventative strategy. So while we are in seek of a way to identify those patients most likely to benefit from the antibiotic envelope, we will have to understand that there are patients that are too sick or too well to benefit because the infection rate is either too low or too high to make a difference with any strategy that is being used. One possible approach to risk stratify those patients who have greater benefit from the Tyrex envelope is to generate risk scores and test them in a different population. For instance, a theoretical approach would be use the risk score generated by the PADID trial and try it into the ROPID trial population. The PADID trial identified risk factors already well known in literature to portend infection, just like the complexity of the procedure, the complexity of the device, here you see, or the clinical status of the patient, immunocompromised or not, or the number of previous pocket entries greater than 2 being the Harbinger of a very poor outcome. So once you generate a score like this, a number greater than 7 would identify those patients with a greater than 3% infection risk. Now, this is a hypothesis, but meanwhile, we have recommendations that we can assume being taught by the ROPIT and the PADIT experience. Tyrex is strongly recommended in specific high-risk settings, just like an early pocket re-entry, whether this is due to lead disorder, hematoma, or pocket revision. In patients with depressed immune defense, just like those having a chronic inflammatory disease, whether on steroids or not, those recently treated of an oncologic chemotherapy, those being on end-stage renal disease or in dialysis. Those patients having vulnerability to surgical site infection, as again by those who have a longer index hospitalization than 1 week before device implantation, or those patients having been hospitalized formerly, or those patients with previous CID infection or chronic skin disease or a pending skin issue by inside-out pressure. Lastly, but most importantly, those patients undergoing complex procedures, just like a lead extraction and reimplantation, an upgrade with addition of 1 or more leads, or those patients already have previous pocket entries greater than 2 or 3. This clearly could benefit from Tyrex use. So, summing up all my recommendations, adherence to a strict prevention protocol is mandatory, keeping the volume per operator high and working constantly in prospective surveillance of the center performance and reevaluation of the risk of the patient before and during the procedure with use of Tyrex in high-risk settings would minimize the CID infection in your clinical practice. Thank you for your attention.
Okay, thank you very much for this excellent presentation. I think it's really an interesting and provoking area. And let's start by a question that was posed by somebody that asked, do you use Tyrex in all your high-risk device cases?
Yes, actually, we have developed a strategy that the patient with a high risk of infection gets Tyrex, and indeed this nearly halved our infection rate, which is around 1.3% per year. So it keeps in track with the ROPIT trial.
So let me ask you the question the other way around. That is, why not to use the system in every patient? So if you forget about the price of the system, do you think this is the ideal way to proceed in the future to avoid infections? It will be really, we should do that in every patient in the future.
Your point is very well taken, and it starts with forget the price, because everything that we do has to be sustainable. But if you look at into the data, there is clearly a major risk factor, which is the number of pocket entries. This is very well highlighted by Arana Rueda, that reported 20% infection rate at the 4th surgery. So if you start from the beginning, from the first implant, having a completely or nearly completely sterile pocket where no seeding occurs, that's a good investment for the second and the third device. So one should aim at proposing this to every patient. For sure, the exception would be those patients who do not have a span of life long enough to reach the first replacement. The average pacemaker recipient today is 78 years old, 75, and with a span of life for dual-chamber device as long as 15 years, it's very unlikely that you have to replace these patients. We hope that average duration of life in our patient will be longer, but we can compute today that if you implant a patient like this, the chances of replacement are 20% of the patients. So you could probably save this investment if this has a cost. For a young patient, and I mean something younger than 70, ideally I would use it at first implant in every patient, just because we are also gaining pleiotropic effect that were presented at HRS, that is less fibrotic capsule formation, which means less adherences on the leads, less chances to have troubles at the replacement. So indeed, this pleiotropic effect is also a good investment for use Tyrex in everyone at first implants.
Okay, thank you very much. We have another question from Petra Kuiper that she asked what happens at the pocket site if you have an unknown allergy for minocycline or rifampin. What's the risk of this allergic reaction?
So far in more than 5,000 patients treated, there has been a report in 2 patients, and one was only a suspected allergic reaction. So I dare say only one was probably documented. And in that case, the patient was deoperated and the envelope was explanted. This occurs obviously within the first 3 weeks, and reopening the pocket carries a risk always. And the best thing you can do at that point is deliver a prolonged antibiotic prophylaxis, even there is no evidence, is the strategy that everyone would do with the reopening, and would use a dedicated antibiotics. That is, if the patient has been hospitalized for too long, the chance of meth-resistant causes is high, so you would use vancomycin instead of cephalosporin. But there have been no massive skin necrosis to tell you in terms of pathologic description. So it's an allergic reaction, that's it.
Great. No, I think this is really interesting field, and so thank you very much for your presentation. I think that we can continue with the session, and we'll discuss another issue that has a lot of relation with this one, that is the leadless pacing, because one of the advantages, of course, is the lack of the lower risk of infection. So if we can proceed with a presentation from Dr. Pachon about leadless, we will continue with the next presentation then.
Thank you.
Thank you.
Good morning. My name is Marta Pachon, and I work as an electrophysiologist in a university hospital in Toledo, a small city very close to Madrid. First of all, I want to thank Medtronic for inviting me to present the latest real-world experience and indications of Micra transcatheter system. The Micra global clinical study was a non-randomized, single-arm, multi-site study in which 56 centers of the 5 continents participated. The primary pre-specified safety, effectiveness, and long-term safety objectives were met with flying colors. But questions remained about the reproducibility of these positive findings in the real world and outside the investigational setting. So the Micra registry was designed to assess the safety and performance of the Micra in the real world, and mainly in the hands of new operators. The first new registry enrollment occurred in July 2015, and the required 9-year registry follow-up period is still ongoing. The methods for analysis are rather the same, like in the IDE study. Now it is ongoing, the Micra acute performance. This is an international prospective, non-randomized, multi-site observational registry. The current total enrollments are 840 patients from 56 activated centers. The first enrollment, the enrollment started on January 2018, and patients will be followed from implant through a maximum of 2 years. So the purpose of this microacute performance renal registry is to gain additional insights into patient selection and validation of the acute safety and performance of the Micra system in clinical practice in the European region. So we will see how is the Micra adoption, how is the adherence to local guidelines, and this race will give us the opportunity to see the local evidence needs and gaps. It will also give us evidence of regional, country, even center safety and efficacy data with a strong focus on the complication risk, mainly the perforation and infusion radius, and also the risk factors of these complications. And it will give us also information about the characterization of anticoagulation strategy and of patient profile. These are the characteristics of the patients included. Multiple comorbidities comparable with the IDE study, but in the registries, in both registries, what it's new and it's different from the IDE trial is that there are 23.9% of patients in the post-approval registry and nearly 40% of the patients in the Micra acute performance that have a condition that precludes the use of a transvenous pacemaker. And also there is a 14.6% and a 21.8% of the patients with a previously implanted cardiac implantable electronic device. And those patients were excluded in the IDE trial. Well, here we have the results of the last database freeze of January this year, last January, and among the 717 patients recruited from 48 centers in 11 countries, the Micra was successfully implanted in all but one patient. The most common indication was bradyarrhythmia with atrial fibrillation, and 284 patients had a condition precluding them from transvenous pacemaker, as we saw in the previous slide. The efficacy objective is being met with very low and stable pacing thresholds through the follow-up. Other electrical values are also encouraging, with R-wave amplitudes and pacing impedances both looking good. Finally, the average projected battery longevity among the patients with a 6-month or longer follow-up is 13.1 years. Since the first Micra was implanted, we have learned a lot. It has been an amazing journey. And we have changed a little bit the implant procedure. One of the main changes is it has been the implant site. As you can see at the beginning, in the IDE trial, 2/3 of the Micra were implanted in the apex and only 1/3 in the septum. That was just the opposite in the post-approval registry, where 2/3 of the Micras were implanted in the septum and only 1/3 in the apex, and this difference is even more evident in the Micra acute performance, in which the 80% of the Micra were implanted in the septum. And this has been very important to avoid complications, mainly to avoid precardial effusions, to avoid perforations. The number of Micra deployments required for successful implant has also improved. In the Micra acute performance, more than 90% of the patients required 3 or less than 3 deployments, and 2/3 of the patients required just 1 deployment. Well, what about indications? Well, Micra has the same indications as a conventional single-chamber pacemaker. So any patient with a class 1 or 2 indication for a single-chamber ventricular pacemaker, VVI or VVD, can benefit from Micra. Of course, there are some patients that can benefit more, and mainly are those with a higher risk of complications of transvenous pacemakers, like those under dialysis, etc. And of course, there is a subgroup of patients in which the Micra can have a very important role. This subgroup is those patients with a prior device, cardiac electronic device infection. When we think about Micra as an alternative to conventional transvenous pacemaker in this subgroup of patients, it's because we think that the incidence of infection with Micra is lower, but we have evidence of that with the real world, where's the incidence of microinfection in the real world? Well, there were no microinfections that required micro removal in the more than 2,500 patients included in the IDE trial and in the Micra post-approval registry. And this is a very important data. 16 patients in the Micra IDE study had a serious infectious event, bacteremia or endocarditis, and Micra was in fact removed in one patient who received an aortic valve replacement 430 days after the Micra implant, but no vegetations were seen on Micra. None of the remaining cases required device removal, and all responded well to antibiotics. So Micra did not appear to lead to device sealing. Well, there are many potential reasons that leadless pacemakers may be resistant to infection, including some are very obvious, like the absence of subcutaneous pocket and lead. Of course, the size, Micra is much smaller. A very important one is the reduced skin and glove contact during the procedure. Of course, the encapsulation, here in the pictures, you can see different grades of encapsulation. The location is also an important one. The turbulence environment in the right ventricle probably inhibit bacterial adhesion. And another important one is the device material. In fact, there is a very recent study that compared bacterial growth on polyurethane coated bare or parylene coated titanium surfaces. And they found that parylene coating significantly reduced the ability of bacteria to grow in colony count assays, suggesting that this could contribute to the reduction of bacterial infection of Micra transcatheter pacemakers. But what is the real-world experience of Micra in patients with a prior device infection? Well, here we can see data from the Micra post-approval registry. In this registry, a total of 105 patients with a prior device infection underwent a Micra implant. All system components were explanted in the 93% of the patients, and the explant occurred a median of 6 days before the Micra implant, with a 37% occurring on the same day of the Micra implant. Well, Micra was successfully implanted in nearly all the patients, and the median length of hospitalization following the Micra implant was pretty low. It was only 2 days. And the most important is that there were no Micra device explanted due to infection. This is another publication that included 17 patients receiving a Micra in the same procedure as the infected cardiac device explant. There were no procedural complications. Of course, all patients were under antibiotic treatment. 4 patients had a positive blood culture at the moment of the Micra implant, and there were no recurrent infections during the 143 days follow-up. So these and other evidences have been highlighted in the last ERA consensus on how to treat the cardiac implantable electronic device infection. As you can see here, alternative novel devices such as leadless pacemakers may be considered in selected patients with high infective risk, and after a device infection. So finally, in conclusion, the Micra post-approval registry continues to show that in the hands of new operators, Micra can be implanted safely and effectively with a very, very high implant success rate and a very low rate of major complications, very low rate of pericardial effusion, device dislodgement, and infection. This real-world data reinforce the positive results seen in the IDE study. Also, the Micra acute performance continues towards septal placement with 80% of the Micras placed in the septal region. Also, is showing very stable patient thresholds through the 6 months after follow-up after implant, and expected battery longevity is 13.1 years. As we have seen, the Micra has the same indications as a conventional single chamber ventricular pacemaker. Of course, some patients can benefit more. We have seen that Micra is more resistant than transvenous pacemakers to bacterial seeding. So it appears to be a safe alternative in patients with a cardiac implantable electronic device infection. If you have any question, I will be pleased to answer them. Thank you very much.
Thank you, Marta. Excellent presentation, excellent overview. And well, I think there may be many questions that, but the first one I would like to comment with you is, what do you think about the same-day exchange? When you have an infection, it's always a problem, especially in patients that are pacemaker dependent, and you have to keep them in the hospital and then do pacing and wait this time. So I think it's very interesting, the results showing that in this, of course, a small population, you can do that in the same procedure and the same day, and that would be certainly a big advantage. I don't know if you have any personal experience, or what are your feelings about that? Or should we proceed with that and do a kind of registry to gain some more data on that? Because I think it's an important point.
Yeah, of course. I think this is one of the most important points. At the beginning, when we started with the Micra a few years ago, what we used to do is what is indicated in the guidelines, no, to wait until antibiotic therapy is completed. So in patients, patient dependent, we used to implant and conventional lead with an external pacemaker. So the patient hasn't to be in the coronary unit in an intensive care unit, and he could do pretty normal life in hospital life, no? And well, but it's not a good solution, because that means that the patient has to be in hospital for at least more than 1 week. You know, usually they used to stay 2 weeks. So since a few months, I think 2 years ago, we started doing the Micra implant in the same procedure as in the same day as the device explant. No, I know that we still don't have strong evidence about the safety of this procedure, but it's very convenient for patient-dependent patients. And in my experience, patients are going well, and we have no evidence of Micra infection in these patients. So although we will need more evidence to have a guideline-based indication, nowadays a lot of people, we are doing that, and our experience doing that, it's a good experience. So it's what we used to do. We do it in the same day.
Then what I would do is encourage you to do a registry, get in touch with other people and see how many people is doing that and what has happened.
Yeah, that's the only way we will have strong evidence, no?
I think, but I think it's a really interesting point. Another thing that I would like to ask you is, do you have any experience with the same-day discharge? Because apparently, if you have a conventional pacemaker, you can be sent home the same day and so on. And there's been some reluctancy saying, okay, because this is a femoral approach, you can have bleeding, etc. No, and I don't know if there's any data regarding this in the registry, and or if you have any personal experience on what do you do. In our hospital, we keep them one day, so they spend one night in the hospital, but it's something that I certainly would like to explore, because it save one night in the hospital, it's always important. So I don't know what your experience and what do you think about that.
Yes, well, that's a very interesting point. What we do is, we keep the patients also one day. No, I know it has been published some experience about discharging the patient the same day in a group that is doing the jugular approach. One of the advantages of this approach, they discuss that they can discharge the patient the same day. But personally, I have no experience about that. No? What we do is we keep the patient in rest for 8 hours. After 8 hours after the implant, he can stand up and the patient can walk 8 hours after the procedure. But we keep them until the day after.
Yeah, but I think really that, for instance, it should be, maybe the risk is even lower than when we do that for instance, AFib ablation, and the patient is under severe anticoagulation, and sometimes you see hematomas the day after, but of course it's a much risky situation. So I think it's another idea here to do a registry about that, because it's really a good point if you can send the patient home. So
Yes, because with conventional pacemakers, we do that, no? So I totally agree with you. Mm-hmm.
Perfect. I hope you continue to totally agree with me the whole life, and we have a nice
yes, we have a lot to organize, no?
No, it's been really a nice presentation. Thank you very much for this nice presentation.
Thank you very much.
I think we have to proceed with the next presentation by Dr. Amir Zaidi, and he will talk about these new devices with AV synchrony. What can we expect from them? Thank you very much, Marta. Thank you.
Thank you.
Hello, I'm Amir Zaidi. I'm a cardiologist at Manchester Royal Infirmary in the UK, and I'd like to talk to you about the future of cardiac rhythm management, which I firmly believe is with development of leadless technology. And we've had Micra VR for some years now, and it's been an extremely successful device. It is largely implanted for patients with bradycardia, with permanent or persistent AF. But we've been expanding the indications, so there is a significant number of patients with sinus node disease and AV block who received a Micra. But it's VR pacing. And the reasons we've given them a VR device is usually because of issues like advanced age, sedentary lifestyle, or because of comorbidities such as infection or renal failure. And one of the things I think we all like about the Micra VR is it's been a device with very low complications, and compared with historic controls and with recent studies looking at complications with VVI pacing, the risk of complications with Micra VR has been around a quarter to a third of what the complications we'd normally expect with leaded devices. The problem is it's still only a VVIR pacemaker, and as a proportion of the pacing that we do in the modern age, it's only around 15% of patients who fall into traditional VVIR pacing indications. And we're excluding a large group of patients with issues like sinus node disease and AV block. So what we really need is a leadless device that's capable of providing AV synchrony. And that's where Micra AV comes in. So all of the Micras have had a 3D accelerometer within them, and using clever software techniques, the engineers have allowed us to identify 4 separate sounds on the accelerometer. The A1, which is the first heart sound, A2, which is closure of the aortic and pulmonary valves, but the 2 important ones are A3, which represents passive ventricular filling, and A4, which is atrial contraction. And by using A4 to trigger ventricular pacing, we can now provide AV synchrony. And we've looked at the use of the algorithm in patients with existing VR devices. I would stress that this is not something that allows backwards compatibility on existing VR devices, but software can be written onto existing Micra VRs, which allows short periods of the AV synchrony algorithm, the Marvel algorithm, to test the use of AV synchrony. And in the initial study, the Marvel study, the algorithm was loaded into 64 patients with existing Micra VR devices and showed that we were able to get AV synchrony in around 90% of patients, and that was true both of AV block patients and intrinsic conduction patients. And what we found was that the problems with developing the AV synchrony algorithm were patients with low A4 amplitude. So it was difficult to see or hear the 4th heart sound, and therefore to trigger AV synchrony. But the important thing in the initial study was that AV synchrony could be provided, and there were no adverse effects related to the algorithm on the device. Marvel 2 was a follow-on study using an improved algorithm, one which automatically set important parameters to allow AV synchrony, but also provided mode switching to ensure that we were minimizing RV pacing to patients where it was really needed, and allowing mode switch to VVIR pacing for periods of high atrial activity. And one of the things I think that we all recognize is that when the heart rate goes above 95 or 100, it's not the presence of AV synchrony that's important, it's really providing appropriate rate support. And we also looked at parameters which could identify patients where recognizing the A3 and A4 signals were going to be problematic. And one of the things that was particularly useful in this study was looking at echo parameters to identify patients who were likely to have problems. Again, the Marvel algorithm worked well, rather better than in the Marvel 1 study, AV synchrony up to 95%. And as you might expect, AV synchrony improved stroke volume and decreased sinus rate. So it's showing the correct and important physiological parameters that we want with providing AV synchrony. And one of the most helpful things was that the echo parameters, which we are used to measuring, the E wave and the A wave, and simple measures like atrial contraction excursion, were predictable in terms of the size of the signals that we needed. So there were very few things that played a significant, had a significant impact on the A3 and A4 signals, but the E to A ratio on echo and the atrial contraction excursion were significant predictors of either good or bad results in terms of the working of the algorithm. One of the things that was particularly striking in the Marvel 2 study was that no patients who had an E to A ratio above 1.5 on echo had greater than 90% AV synchrony, and that's the sort of level of AV synchrony that we should be aiming for. And the other thing that was important is the position of the device had no real influence on the A4 signal amplitude. So in terms of implant technique, it's exactly the same as for Micra VR, and the placement of the device does not affect the efficacy of the AV synchrony algorithm. So Micra AV has worked well in studies. It now has FDA approval and CE mark. The implant technique is exactly the same as for Micra VR. It's implanted in VVI mode. You then start the atrial setup algorithm, and then you ensure that you have AV synchrony by mechanical troubleshooting in recovery, and you can then program the patient to VDD mode. We have a number of new Micra AV diagnostics. There is a mechanical manual atrial mechanical MAM test, which allows you to press and hold and ensure that you have appropriate AV synchrony, and is extremely good for troubleshooting. There are also three key features which ensure that we're maintaining or recovering AV synchrony when there is a loss of atrial sensing. A loss of atrial sensing is obviously a big problem in terms of maintaining appropriate AV synchrony. So we have rate smoothing, which provides AV synchrony during atrial undersensing. We have tracking check, which ensures that there's appropriate tracking of the correct physiological signal, and there is automatic adjustments of the PVARP so that we have adjustment based on the heart rate. As we've said, mode switching is important. So although the Micra AV mainly works in VDD mode, at periods it will switch to VVI plus, where it will test to see whether there's intact AV conduction to try to minimize ventricular pacing and preserve battery life. And when there's high rate activity, it will mode switch to an activity mode, which is VDIR, to provide rate support during exercise. One of the important things in Micra AV excuse me, is battery longevity. So we do not want a significant loss of battery longevity compared with Micra VR, which has proven extremely successful in terms of providing good long-term VVI pacing. And one of the things that we would all expect in Micra AV is to have the same range of diagnostics that we have with traditional leaded devices. So on the rate histograms, it will give a percentage of the different types of pacing behavior, VDD, VVI plus, and AV conduction mode switch, and will also display the overall pacing percentages to allow us to troubleshoot patients where there is a problem. And we can have a further range of diagnostics so that we can ensure that we're providing the best parameters in terms of maintaining AV synchrony. Longevity is very good. Predicted longevity, obviously, at this stage, but depending on the amount of pacing, we would expect between 8 and 15 years in VDD mode. So the predicted longevity is very similar to what we already achieved with Micra VR. So in summary, Micra AV provides accelerometer-based atrial sensing, which significantly improves AV synchrony in patients with AV block. It is not 100%, but it is over 90% in the vast majority of patients, and with appropriate rate support and mode switching, it will provide good long-term VDD pacing. The implantation is exactly the same as for Micra VR and is a proven safety. Simple echo measurements pre-implant may help select patients who are going to get the most benefit from the AV synchrony algorithm in Micra AV. And we get good longevity, up to 15 years, depending on the amount of ventricular pacing. And so far, we've seen no adverse effects, particularly in Marvel 1 and Marvel 2 studies. Thank you very much for listening. I'd be happy to answer any questions.
Well, thank you. I mean, it's been a great presentation. I enjoyed it very much. And I think it really opens a new opportunity of indications for leadless pacing. And we have some questions from the audience here. One of them is, do you think it's always necessary to perform an echo prior to implantation? And would you recommend that? Or do you think simply just go ahead and implant and see afterwards if it works or it doesn't? Yeah.
Well, I've talked about echo, and I think it gives us an option in patients where we're particularly concerned about A4 amplitude. But in practice, I don't routinely perform an echo. If I've got a patient with AV block who I think will benefit from a pacemaker, and there are high-risk features which suggest that a leadless device is going to be better or safer, then I'll just go ahead and implant without an echo.
Okay. But in the end, the patients that show the lowest contraction of the atrium are the ones that has less synchrony, but probably are the ones that benefit less from the synchrony because already had a little contraction or little contribution of the atrium. No? So that's more or less, that would be an argument saying, okay, if you will just miss probably those that already have an atrium that is not very contributive in the contraction.
Yeah, I think that's
another issue is then what would you think about using it in a regular basis? I mean, it's forget about the price. Okay, you can go and implant a traditional BDD system, or you go for this spacing. And what's the advantage? Do you think in 5 years' time that this is the alternative and that this is not just a specific niche of patients, but for everybody? What do you think about that?
I think it will be driven by patient demand. So I think younger patients want to avoid having to have a more complex procedure. They don't particularly like having their chest scarred, particularly women. They don't particularly like having a device in the chest, which is obvious. So I think we will have a demand from patients to put in leadless devices rather than leaded devices. Of course, cost is going to be the big issue. So it's going to be a time before it's the standard technique for treating AV block. But I personally am very fond of safer procedures. So I think that it's a proven procedure with a low complication rate. It's a quick procedure, so usually it'll be done in 20 minutes. For older patients, I think it works very well, but I think younger patients have the most to gain from this technology. Okay, there's another question from the audience saying, typically what kind of patients do you implant at present, taking into account all the limitations? Yeah, I mean, it's been a small number of patients. Unfortunately, COVID has I think, impacted all of us in terms of our activity. But I'm using it mainly in those patients where there are particular concerns about a traditional implant. So post-infection, patients with renal failure, particularly those on dialysis, patients with very low body mass, where a traditional leaded device is going to be an issue. And those are the patients I'm mainly concentrating on at the minute. But I personally give all my patients the option of choosing a leaded device or a leadless device. And I find that most of them prefer a leadless device.
Yeah, absolutely. I agree on that. And then probably we have to consider that there will be patients who really will put the strength and in favor of this technology, because of course nowadays it's a limitation of the price, etc. But I see a lot of advantages. Okay, so thank you very much, Amir. It's been a great pleasure to share this time with you. And we are reaching the point of closing the session. I would say that the session, the conclusions, we have discussed with the new systems to avoid infections. And again, I think it's a big jump. It's a big advantage, and still there are the limitation of prices, and we have to select the appropriate patients. That would be those having replacements, etc. But it's really a big achievement. And then we have heard about the registry, and we have had more reassurances that leadless pacing is safe, is working very well, and it's a very nice option in patients that have really difficult access, a lot of chances of getting infection, etc. And finally, the very exciting new development of the AV synchrony in these devices. It's really marvelous that you can really synchronize the atrium and the ventricle just with the sensor that is able to capture and to synchronize the atrium just with a single leadless pacing. And the results are really encouraging, and I think it's going to be a great technology for the near future. So thank you very much, everybody. With that, thank you your interest in the subject, and thank you all the speakers and the audience. Thank you very much, and see you. Bye. Enjoy.